Okay, so good evening, colleagues. Welcome to this weekend tutorial. And today we'll be looking at a very common topic, local anesthetic agents. I want you to put on your thinking cap. You'll be surprised to know that it's not as simple as it sounds. So local anesthetic agents, at the end, I expect you to be able to define local anesthetics and describe their mechanism of action. As well, you'll be able to differentiate between ester and amide. You'll be able to understand the pharmacokinetics and pharmacodynamics of local anesthetic agents. And you should be able to identify common LAs used in clinical practice, and also be able to discuss the factors that influence the choice of a local anesthetic agent. And last but not the least, should be able to recognize the potential complications associated with the use of LAs and how to manage them. All right, we're going to follow this outline this evening. So before we go on, let's attempt this case-based MCQ. All right, there are 5 of them, the case-based MCQ. All right, let's look at where we are in our knowledge base. So the first question is, a 40-year-old man undergoes excision of a sebaceous cyst under local anesthesia. The surgeon chooses to use lidocaine 1% without adrenaline. After administration of the LA, the patient suddenly experiences dizziness, tinnitus, and perioral numbness. So what is the most likely cause of his symptoms? A, anaphylactic reaction to lidocaine. 2, systemic toxicity from local anesthetic overdose. 3, vasovagal syncope due to needle insertion. 3, allergic reaction to epinephrine. And D, delayed onset of local anesthesia. Anybody wants to take a try? What is the answer here? Anyone? No attempt? Okay, if no attempt, we'll go to the second question. A 28-year-old pregnant woman in labor requests epidural analgesia. The anesthetist decides to use bupivacaine. What do you think is the main reason bupivacaine is preferred over lidocaine in epidural anesthesia or labor analgesia? A, bupivacaine has a faster onset of action. B, lower risk of cardiotoxicity. C, prolonged duration of action. D, stronger motor blockade. And E, less risk of fetal accumulation. Any attempt?
C.
Sorry?
C.
Okay, C. Do we agree Dr. Dana said C?
Yes, C is the question.
Okay, what about A? Anybody still trying to attempt A?
B.
B, correct. Okay. A 50-year-old patient with end-stage liver disease requires a brachial plexus block for an upper lip surgery. Which of the following local anesthetics will be most appropriate for this patient? A, bupivacaine. B, mepivacaine. C, lidocaine. D, tetracaine. E, procaine. Any answer? Okay. While we are thinking about that, let's go to number 4. A 35-year-old man with hyperthyroidism requires a dental procedure Under local anesthesia, the dentist plans to use lidocaine with epinephrine. What is the main concern in this patient? A, increased risk of methemoglobinemia, delayed onset of action, increased risk of hypertensive crisis, increased risk of allergic reaction, decreased efficacy of lidocaine. Any of these, anybody wants to attempt any of these two questions? Dr. Diana, you've been coming to our aid. Come to our aid again. We have a lot to talk about. Anybody?
Question 4, number C. Question 4C.
Question 4C. Let me see again. I don't think so. Any other attempts?
Question 3E.
Question what?
3E.
E. Why?
Yes. Because it's an ester not metabolized by the liver. That's what I'm thinking.
Yeah, but that's not the only ester that is there. Tetracaine is also an ester.
Oh, that's true. It's either one of them.
All right, good thinking. All right, but the answer, the most appropriate answer will be E because it has a faster onset of action. Okay. All right, so.
I think question 1 is B, the toxicity.
Yes, you are right. We've left question 1, correct. So we are question 3 and 4 now. Nobody? Question 4, going. Okay, let's look at question 5. Oh, the answer is already here. Why did I put the answer here now? Don't look at the answer. Look at question 5. A 60-year-old diabetic man with peripheral neuropathy undergoes a Beer's block for carpal tunnel release. Lidocaine 0.5% with epinephrine is injected intravenously after tourniquet inflation. What is the main risk if the tourniquet is accidentally deflated too soon? Anybody? Even though the answer is there, B, isn't it? Do we agree with B?
Yes.
Yes. The answer is B. Yes.
Did somebody answer 4 and said C or D? I didn't get that. I'm trying to remember somebody tried to answer question number 4, isn't it? Okay, let's move on. All right, so this is a discussion-based question. A 60-year-old male patient undergoes spinal anesthesia with bupivacaine for a total knee replacement. 4 hours later, he is unable to move his legs despite resolution of sensory block. So, discussion point. What do you understand by differential motor and vasosensory blockage? 2, what are the factors that affect duration of action? And what will determine your choice of local anesthetic agent for spinal anesthesia? So these are discussion points we'll try to find answers for as we move on because of our time. Okay, the second one is a 28-year-old patient is undergoing dental extraction suddenly develops generalized urticaria and bronchospasm after receiving procaine injection. He has history of multiple drug allergies. So, discussion point, how do you differentiate this clinical scenario from systemic toxicity? Is this hypersensitivity or systemic toxicity? And how will you differentiate it? In terms of hypersensitivity reaction, discuss esters and amides, local anesthetic agents. And what alternative agents will you use in this patient? All right, these are discussion points we will find answers to as we go on. If I'm involved in setting your questions, some of these questions will be useful for your exams, both part 1 and part 2. A 45-year-old male patient undergoes a brachial plexus block for hand surgery. 10 minutes after injection of 40 mils of 0.5% bupivacaine, he complains of tinnitus, dizziness, followed by generalized seizure and cardiac arrest. So how will you manage this patient? Number 4, case-based scenario question. A 30-year-old woman with an infected foot abscess presents for incision and drainage under local anesthesia. Despite injecting lidocaine with adrenaline, she continues to feel pain. So what would be your explanation? And you discuss the effect of acidic environment on the action of local anesthetic agent. What is the role of PK in onset of action? And what strategies are you going to employ to improve the efficacy of lidocaine in this patient? Do we understand that? Okay. So let's dive into the discussion for today. LAs are drugs that produce transient and reversible loss of sensory, motor, and autonomic system function in a discrete part of the body. All right? It's a transient, reversible loss of sensory, motor, and autonomic system functions. All right? They are widely used in regional anesthesia, pain management, and minor surgical procedures. All right? The first known local anesthetic agent was cocaine. All right? The first and the only naturally occurring LA derived from the coca plant, the Erythrosylum coca. All right? The indigenous South Americans used these coca leaves for their stimulant and analgesic effect. Albert Niemann was the first to isolate cocaine in 1860. And Carcola, the ophthalmologist, was the first to demonstrate the local anesthetic use of cocaine for eye surgery. All right, procaine was the first synthetic local anesthetic agent introduced in 1905 by Alfred E. Horn. Okay. But he had a short duration of action and was bedeviled by high risk of allergic reaction due to its metabolism to powder. The first amide local anesthetic agent that was introduced by Lofgren and Lundquist was lidocaine in 1943. And the advent of lidocaine in 1943 revolutionized regional anesthetic practice. After that, we had other amides like the bupivacaine, mepivacaine, levobupivacaine, and ropivacaine. So lidocaine was the first amide local anesthetic that heralded most of the local anesthetic we have in clinical practice. So the properties of an ideal local anesthetic agent, it should be local, okay? L means that it should have a low systemic toxicity. The onset of action must be short. It should cause no permanent nerve damage. All right, and when applied locally, it should have good effect, and it should have long duration of actions. All right, so I compressed all the properties of an ideal local anesthetic agent into this mnemonics local. Okay, so classification, there are different ways to classify local anesthetic agent. The common ones is that based on the chemical structure, local anesthetic agents can be classified into esters and amides. All right, they can also be classified based on their duration of action into short-acting, e.g. procaine and chloroprocaine, the medium-acting, lidocaine and prilocaine, and the longer-acting that can last for between 4 to 8 hours. Examples there are bupivacaine and ropivacaine. Okay, so broadly, esters and amides may be differentiated based on their stability in solution, their metabolism, their product of metabolism, and their propensity to cause allergic reactions. So esters are unstable in solution, while amides are relatively stable. All right, the esters are metabolized by pseudocholinesterase, while amides are metabolized by the amidases, which are liver metabolism liver by the cytochrome P50 enzymes. All right, esters have a product of metabolism para-amino benzoic acid, which most of the time responsible for the allergic reactions of ester, while amides do not have. All right, esters, the question we saw the other time, what are a patient who has hypersensitivity reaction to a local anesthetic agent? What would be alternative? All right, you want to use amide instead of esters for that patient because amides rarely cause allergic reactions. Okay, so how do local anesthetic agents act? They reversibly inhibit nerve transmission by binding to voltage-gated sodium channels in the plasma membrane. And we're going to see the importance of these sodium channels as we go on. So when this occurs, the membrane becomes impermeable to sodium ions, and this prevents initiation and propagation of action potential. Note that the degree of blockage is influenced by the pH of the solution, lipid solubility of the agent, protein binding, and ionization state. Okay, so this is a pictorial diagram of how local anesthetic agents work. So, you know, this is the extracellular area, and local anesthetic through this lipophilic part, you know, permeates through the cell membrane of the nerve. And once it's intracellular, it comes and blocks the voltage-gated sodium channels. So once this is done, it prevents sodium ions, all right, from going out of the cell to propagate action potential. So basically, this is how local anesthetic agents work. Okay, so the structures, if you look at it, every local anesthetic agent has 3 structures. We have the benzene ring, which is the lipophilic aromatic group. We have the hydrophilic ring, which is the tertiary amine, and an intermediate chain, which links both the lipophilic and the hydrophilic group. Note that the type of link between the lipophilic and hydrophilic group determines the group that the LA will fall into. All right, so once it's linked by an ester ring, it's an ester LA. Why it is, if it's linked by an amide ring, it's link rather, it is an amine. All right, so the link between the lipophilic and hydrophilic group determines the classification of the local anesthetic. All right, so very important for us to note that local anesthetic agents are weak bases, and they exist in solution both in the ionized and unionized form. Know that the lipophilic aromatic ring, all right, leads to greater lipid solubility, and this is what enables the local anesthetic agent to readily permeate nerve membranes. On the other hand, the hydrophilic ring, all right, the tertiary amines binds with greater affinity for the sodium channel, and that's where it causes the blockage. So the lipophilic ring helps to move the local anesthetic agent through the nerve membrane intracellularly, while the hydrophilic part is the one that binds to the sodium channel to prevent propagation of action potential. Know that the proportion of the charged or an uncharged form is determined by the pKa of the local anesthetic agent. We're going to see more of that as we go on. Okay, just a reminder, we know nerve conduction. So when we talk about this, we remember the resting membrane potential, all right, which is minus 70. The intracellular part is negative relative to the extracellular part, and this is maintained by the sodium potassium ATPase pump. However, when the stimulus exceeds the threshold potential, the voltage-gated sodium channel is open, and this allows sodium ions, all right, influx into the cell, which leads to membrane depolarization. Action potential is propagated when the wave of depolarization continues and cause more sodium channels to open, which ensures impulse conduction along the axons of the nerve. All right, repolarization. All right, this is when there is an opening of the voltage-gated potassium channels, and the idea is to restore the potential back to its resting membrane potential. During the refractory period, the neuron temporarily resists further excitation, and they prevent excessive firing and ensuring unidirectional conduction. All right, so this is what we have on the right side of the slide. So there are 4 factors, all right, that affect nerve impulse conduction along the nerves. I call it MATES, all right? The number 1 is myelination, all right? Don't forget that nerve fibers can either be myelinated or unmyelinated. Myelinated fibers conduct impulses faster via the saltatory conduction. All right, remember physiology. This is when action potential, instead of just moving slowly, jumps between the nose or rabia. The A is the axon diameter. The larger a nerve is, the better it conducts impulses more rapidly. All right, because there's reduced resistance. Temperature, all right, cold slows conduction velocity, while warmth enhances it. The E, electrolyte balance. So when there's alteration in sodium, potassium, even calcium levels, this can affect nerve excitability and conduction. All right, this is I'm just giving you some of this physiology to remind you. All right, so we have different nerve fibers based on their diameter, based on whether they are myelinated or not. So the A alpha fibers are the largest, all right, with about 13 to 20 micrometer, all right, and they're the fastest, conducting impulses at the rate of 80 to 120 meters per second, all right, and they involve the motor function. The A beta, the A gamma, and the A delta have different diameters with different speed of conduction. Then we have the B fibers. These are small myelinated nerve fibers, but they have slower conduction. and the function of the preganglionic autonomic nerve fibers. All right, the C fibers are the smallest unmyelinated with slowest conduction. All right, and they function at the postganglionic autonomic fibers and pain. For us anesthetists and intensivists, we are concerned more about the A delta and C fibers because these are the ones that conduct pain. You know, the A delta responsible for sharp pain, temperature, and crude touch. Why the C fibers, responsible for dull and burning pain and temperature sensation. It's important for you to know this because even your gate theory of pain, has to do with the diameter of the nerve fibers. Okay, so for local anesthetics or anesthetic agents, we are more concerned with the blockage of the A delta and the C fibers. Okay, so local anesthetic block nerve fibers in a specific frequency, all right? And this is due to the differences in the axonal diameter, the myelination, and the velocity. All right, the first fibers that are blocked, the first sensation that are blocked are the autonomic fibers, all right, or sympathetic. They're the smallest, unmyelinated, so they're responsible for vasodilatation and hypotension. And you remember that when we're talking about spinal anesthesia later on, not today, but later on. So the pain and temperature fibers, like I mentioned, are the next to be blocked. These are the A delta and C fibers. They're small diameter responsible for both sharp and dull pain. A delta for sharp pain, C fibers for dull pain, and both are responsible for also temperature sensation. And that's why, if you remember, some people, instead of using needle prick to test for, whether their spinal anesthesia has fist, they use temperature because the nerve fibers you're interested in are the A delta and C fibers. So we have the touch and pressure fibers, and don't forget that sometimes that's why we need to tell our patients under spinal anesthesia that they may feel touch or pressure. Why? Because that sensation is served by 8 beta fibers, all right, which is a little resistant to the concentration of the local anesthetic agents we use for regional techniques. So proprioception aid alpha fibers, the large diameter, heavily myelinated. These are responsible for motor function, all right? And motor fibers also A fibers. So this is the order of blockage, but the return of sensation is on the reverse order, okay? So we have the autonomic, pain and temperature, touch and pressure, all right, proprioception, and I call it APTTM, all right, for you to remember. So the motor function seems to be the first to return, all right, but the last to be blocked. Early physiology, this is crucial, all right? So sometimes there are certain factors that can be put in place to enhance the potency of a local anesthetic agent, and I call it HEAL, all right? And some of the questions we asked earlier on in our case-based discussion is how, for instance, a patient who, had, what is it called, abscess, and after injecting lidocaine, the patient is still feeling pain. What are the things you can do to increase the potency? All right, this is what we're talking about here. So the addition of a halide group, chlorine and fluoride, increases the potency. So the more chloride or fluoride ion a local anesthetic agent has, the more potent. All right. The ester link, by increasing the lipophilicity, all right, thereby improving nerve penetration, all right, increases potency. Addition of alkyl group, all right, the CH2, also increases lipid solubility and enhances potency. But the primary determinant of potency of local anesthetic agents, the lipid solubility, and that's why I underlined it here. It may come out in questions. So what is the primary determinant of the potency of local anesthetic agent is its lipid solubility. For instance, bupivacaine has a higher lipophilicity than lidocaine. Therefore, bupivacaine is more potent than lidocaine. The onset of action, all right, and this is also very important. All right, I call it MAP. All right, you want to map the LA. All right, the first one is medium. And, you know, for you that want more stuff, molecular weight also can serve as M there. But medium, in acidic medium, all right, for instance, in infected tissue like the one we talked about, all right, there's a slowing of onset of action of local anesthetic agent because in acidic medium, they are more in the ionized form. So membrane penetration is much more reduced. So what do? You alkalize the environment, the tissue, by adding sodium bicarbonate. All right, this increases the non-ionized fraction, so allowing the agent to penetrate the nerve membrane faster and speeding up onset. So one of the things you can do if you want to put an LA in an affected tissue, all right, and what you can do is to add sodium bicarbonate to it, alkalinizing the solution and increasing the onset of action. So additives such as adrenaline, all right, slows the onset of action, all right, but also prolongs it because of vasoconstriction. And the primary determinant of onset of action of local anesthetic agent is the pKa. All right, don't forget that pKa is the pH at which a drug exists both in the ionized and unionized form. All right, so agents with pK closer to physiological pH will have a faster onset of action. Lidocaine, for instance, the pK of lidocaine is about 7.7, which is closer to physiological pH of 7.4. So lidocaine has a faster onset of action than bupivacaine. The duration of action, there are factors that affect the duration of action. The protein binding. So the more an LA binds to protein, for instance, lidocaine is about 95% protein bound, while bupivacaine is about 96, 97. So they have a more prolonged duration of action. All right, liposomal encapsulation. All right, bupivacaine is the only agent that has been encapsulated with liposomes. All right, and so it leads to a slow release and prolonged action. Like I mentioned, vasoconstrictors like adrenaline reduces systemic absorption, so thereby prolonging the action of local anesthetic agent. All right, all I've said is what I summarized here. Let's move on. So PCK, all right, the pharmacokinetics of local anesthetic agent, all right, the absorption after injection is influenced by the vascularity of the tissue, the dose, that is concentration, and the presence of vasoconstrictors. Adrenaline at a dose of 1 in 200,000. And this helps to prolong duration by reducing systemic absorption. Distribution, the more lipophilic LA is, the better the tissue penetration, and therefore have a greater volume of distribution. All right, plasma protein binding, especially bupivacaine, for instance, that is bound to alpha-1 acid glycoprotein. All right, this will determine the free active form. So the more bound the agent is, the lesser its distributions to the tissues. Metabolism, we'll talk about, let me just go into, okay, metabolism. Esters are hydrolyzed by pseudocholinesterase or the plasma cholinesterase, while amides or amides are metabolized in the liver, okay? Primarily, they are excreted in the urine, and some of them have very active metabolites. The excretion is pH dependent, all right? And acidification increases excretion of these agents. Okay, so I mentioned about pKa. I told you that this is what determines the proportion of the drug that exists in the ionized or non-ionized form, that is the charged and uncharged form. So it is the uncharged or non-ionized form that penetrates nerve membrane. I mentioned this before. So aliens with a lower pKa, all right, like lidocaine, we have a faster onset of action. And those with higher pKa, like bupivacaine, pKa of 8.1, we have a slower onset of action. Okay, inflammation and acidosis, that is present in acidic medium. This reduces the non-ionized fraction. I mentioned this before. Let's move on. All right. So I mentioned this before. All esters are metabolized by cholinesterase except, all right, this is an MCQ question, except cocaine. Cocaine is an ester, but it's metabolized in the liver. All right, and its product metabolism can also be affected by concomitant consumption of alcohol. Okay, amides are metabolized by the macrosomal enzymes in the liver, this cytochrome P40, and it has a slower metabolism compared to ester hydrolysis. So how do you know the concentration of a local anesthetic agent? The concentration is usually expressed as a percentage, which is measured in grams per 100 mils. So for instance, when we say 1% lidocaine, what we mean is that there's 1 gram of lidocaine in 100 ml solution, all right? Or 1,000 milligram in 100 ml, or 10 milligram per ml. Okay, so the easiest way to do this is that, for instance, bupivacaine 0.25%, it means it contains 2.5 milligram per mil. You just move the decimal point forward. All right, lidocaine with 1% lidocaine, what it means is that there's 10 milligram per mil. And this helps you to determine the maximum dosage of a local anesthetic agent you're going to use, either with vasoconstrictor or without vasoconstrictor. So we need to know what the concentration is and what each concentration means. For instance, for when we want to do work in epidural, we can even double or quadruple dilute the bupivacaine. All right, if you have 0.5%, you can double dilute it to give you 0.125%. Okay, and that helps, all right, to reduce the motor blockage of the bupivacaine, and it helps the parturients with epidural to ambulate, and which also speeds up the labor process. So look at anesthetic adjuvants, the adrenaline I mentioned, sodium bicarbonate, all right, alkalizes the solutions of local anesthetic agent and helps to increase the proportion of the uncharged drug for faster onset. Many of us, many of you, especially those who have done part 2 or who are trying to do part 2, there are different adjuvants that have been added to LA that tends to prolong the duration of action. Clonidine, for instance, all right, enhances the analgesic property of local anesthetic agent by prolonging the duration of the block. Desmetomidine, which is a more selective alpha 2 agonist, has also been used. All right, and the advantage of desmetomidine is that it's sedative, so it keeps the patient calm while prolonging the duration of your local anesthetic agent. Dexamethasone, opioids, ketamine. Interestingly, ketamine has been used, all right, to reduce postoperative pain in regional anesthesia, and these are all adjuvants that can be added to your local anesthetic agent. Okay. So while we're talking about, I need to remove this. Oh my God, where am I? Okay, so we're talking about adverse effects. We have different adverse effects. CNS toxicity, all right, which is due to excessive plasma levels of local anesthetic agent, and this could lead to inhibition of neuronal activity. All right, the earliest symptoms of CNS toxicity is usually excitatory, but as the symptom becomes severe, it can become depressive. All right, severe toxicity results from direct myocardial depression and vasodilatation due to the sodium and calcium channel blockade. And bupivacaine has less affinity for the sodium channels of myocardia, so it's less cardiotoxic than the parent agent, bupivacaine. All right. So severe effects of severe toxicity can include arrhythmias, conduction block, and cardiac arrest. All right. So the cardiotoxicity of bupivacaine is due to a specific effect on the sodium channel myocardium. Well, they call the Aquinas syndrome. Is rare, but severe complication. All right, that is associated with the 3 Bs, as we'll see later on if we get there. The back pain, which is severe. Then we have bilateral limb paralysis, and then we have bladder and bowel dysfunction. So the 3 Bs of Corda Aquinas syndrome. All right. Then we have hematological effect, especially with some agents like prilocaine, benzocaine, all right, and lidocaine for instance, especially in high doses. Okay. Now this is caused by oxidation of the ferrous ion in hemoglobin to ferric ion, and this reduces the oxygen carrying capacity. And this is important so that when patients have reduced oxygen level, you want to avoid agents that can cause methylglobinaemia. All right, the symptoms include cyanosis, dyspnea, tachypnea, and you have a chocolate-colored blood. All right, the treatment is given 1 to 2 milligrams per kg of methylene blue, which reduces the methylglobin back to the normal hemoglobin. All right, we have hypersensitivity reactions to LA. It's common with ester agents due to the para-aminobenzoic acid production, which is immunogenic. All right, so we can have different types from mild, moderate to severe. And we have the autonomic effect commonly seen following neurasia block. All right, it can either be due to sympathetic block, all right, especially for high spinal, block above T4, all right? And then you can have even effects on the GI with unopposed parasympathetic activity, leading to increased peristalsis, nausea, and ileus. Okay, I've mentioned this before because of time, okay? Now, note that Corda Aquinas syndrome is a clinical emergency which requires immediate evaluation. Diagnosis is usually confirmed with MRI of the lumbosacral spine, which can help to identify the level and the cause of the compression. All right. So it's a surgical emergency that requires urgent decompression. I remember years ago, post NYC, we had a patient who had Corda Aquinas syndrome that almost became a medical legal issue. All right. So urgent decompression, either laminectomy or discectomy within 24 to 48 hours improves neurological recovery. All right. Delayed treatment may lead to permanent neurological deficits, all right, which include chronic bowel, bladder, or sexual dysfunction. In as much as you're doing that, supportive measures include catheterization, pain management, and physiotherapy. All right, we talked about hypersensitivity reaction. We go on, and this adverse effect you have when you have access to the slide presentation, you can have them. All right, the systemic effects is usually measured by what we know as the CC-CNS ratio, all right, which is defined as the ratio of the drug dose required to cause catastrophic cardiovascular collapse, all right, to the drug dose required to produce seizures. All right, so when a drug has a low CC-CNS ratio, is associated with more cardiotoxic properties. So, for instance, bupivacaine has a low CC CNS ratio, so it's more cardiotoxic than LAs, which have a higher CC-CNS ratio. So agents with higher CC-CNS ratio are said to have better safety margin. Okay. All right. So the intravascular injection of local anesthetic agent can produce signs and symptoms of LAST, known as the local anesthetic systemic toxicity, which can be fatal if not recognized and treated promptly. All right. So there are different mnemonics. You can use early toxicity can cause sudden cardiac arrest, or you can use a Christmas. All right. Mnemonic. So signs of local anesthetic toxicity can be Christmas, confusion, hypotension, respiratory depression, involuntary muscle twitching, seizures, tinnitus, metallic state, arrhythmia, and syncopal attack. All right. So when you're thinking about LAST, think about Christmas. So how do you manage it? Let's go into let me see. Okay, let's do it this way. Okay, how do you manage it? The first thing is you want to recognize it. Early recognition is important. Okay, then once you recognize that there's a systemic toxicity here, you discontinue your injection. You call for help. You maintain airway and give oxygen by 100%. You control seizures with with your benzodiazepine. Obtain blood for blood gas analysis and administer intralipid. All right, at the bolus of 1.5 ml per kg over 2 minutes. Then you continue the infusion at 15 ml per kg per hour. You can repeat the bolus, all right, as you examine your patient between 5 minutes in interval. All right, repeat infusion at 30 minutes, double your infusion dose until there's cardiovascular stability. All right, so this is just a mnemonic of how to go about that. All right, I just presented something about intralipid for your interest. All right, so individual agents, how do you recognize esters from amide? There are two ways I do that. All right, number one is amide have two eyes. All right, and the eye usually comes before the cane. Okay, so if you look at like lidocaine, mepivacaine, prilocaine, bupivacaine, etidocaine, ropivacaine, they always have two eyes. Not I that we used to see I as a letter. Okay, and the I usually come before the cane. Why esters have only one I? The cocaine, procaine, tetracaine, chloroprocaine, and benzocaine. All right, quickly, because of our time, we just look at some of the commonly used agents. Cocaine, we need to talk about it because it's the first and only naturally occurring local anesthetic agent. All right, it's classified as ester, but it is metabolized in the liver. Okay, unlike the other esters that are metabolized by the pseudocholinesterase. All right, it produces its effect by binding reversibly social channels. It also blocks norepinephrine reuptake in the autonomic nervous system, also prevents the reuptake of dopamine and serotonin. And its effect on dopamine is what is responsible for its addictive potentials. Metabolized in the liver to benzoergognine, all right, in the presence of alcohol, the metabolite becomes more toxic, the cocaethylene. It's used as a topical agent for mucous membrane in the eyes, oral cavity, the larynx, especially when you're doing bronchoscopy and all that. Okay, it's also effective in shrinking mucous membranes, especially when you have epiglottitis. All right, it helps to shrink the epiglottis. So cocaine toxicity is cocaine convulsions, overdependence, there's addiction, coronary insufficiency, arrhythmia. It can lead to increased blood pressure, increased blood temperature, and all that. Chloroprocaine, all right, is an ester, all right, and it's hydrolyzed quickly by plasma esterase. It has a low potency and short half-life, making it ideal for epidural anesthesia. Okay, it provides effective sensory and motor blockade, but the problem why clopropene has been disfavored is that it produces more motor block than sensory block, which is undesirable for a local anesthetic agent. All right, its major advantage is that it has low systemic toxicity because it is rapidly hydrolyzed by pseudocholinesterase. But there's been concern about neurotoxicity, all right, especially when used in spinal anesthesia. Although modern formulations of the drug have reduced the preservatives, which has improved its safety profile. All right, clinical uses still include spinal anesthesia, epidural, peripheral nerve blocks, and all that. No other side effects may include allergic reactions, transient neurological symptoms when used in spinal anesthesia. Prilocaine is an amide. Know that it has double I's, all right, with intermediate potency and duration of action. It also has good systemic toxicity profile and is suitable for regional anesthesia and BS block. But one of the features of prilocaine is its metabolism to ortoludine, all right, which is a compound that can cause methemoglobinemia, like we mentioned before. Okay, so despite the risk of methemoglobinemia, it is favored for epidural anesthesia. It's also a component of your deuterated mixture of local anesthetic agents, all right, and which is found usefulness in topical anesthesia, pediatric, and dermatological procedures. Don't forget the treatment, methylene blue, we mentioned that before. Then benzocaine, let's go to lidocaine. Yeah, lidocaine, common one, is a weak base with a pK of 7.7, all right, and it's about 65% protein bound. Okay, maximum dose without vasoconstriction is 3 to 4.5 milligram per kg, and when you're adding vasoconstrictor, you can increase the dose to 6 to 7 milligram per kg. All right, there are a lot of usefulness for lidocaine, lidocaine, which I call lidocaine. It can be used for local skin infiltration, intranasal or intraoral spray before endotracheal intubation. Can be used for dermal patches with 5% concentration to reduce shingles pain, ophthalmic drugs for short ophthalmic procedures. It can be used to suppress cough. It's an antiarrhythmic, a class 1B antiarrhythmic drug for ventricular arrhythmia, useful for nerve blocks such as ankle blocks. And patient neonates with epilepsy, lidocaine has been found as the second line treatment, especially if phenobarbital fails to stop the seizure. Bupivacaine is an amide with a longer side chain, all right? That means it has higher halide group, okay, compared to lidocaine, okay? It is not soluble in water, but it comes in bupivacaine hydrochloride, all right? The acidic component makes it more soluble, and that is how it is used. It's about 95% protein bound, all right, and which prolongs its onset of action. Is metabolized into 2,6-pipercolocylidine, which is mainly catalyzed via cytochrome P450. Okay, and usefulness, it comes in different concentrations, like we said. I like to ask my medical students to compare lidocaine and bupivacaine. All right, and it's a good question for medical students. Right, levobupivacaine don't forget that bupivacaine, exists as enantiomer. So we have the levobupivacaine is the S enantiomer of bupivacaine, which has been developed to reduce the cardiotoxicity associated with bupivacaine. It provides long-acting anesthesia with potent sensory block and relative motor sparing. So there are two advantages. Levobupivacaine is less cardiotoxic. It causes motor sparing effect. We have what we call the motor sensory differentiation. All right. It has a severe cardiovascular CNS toxicity profile that we mentioned before. Why? Because it has less affinity for cardiac sodium channels. Okay. So it's preferable for patients high-risk group. Ropivacaine is an amide, less toxic than bupivacaine, all right? But it has a lower lipophilicity, which reduces its ability to penetrate myelinated motor fibers. And this is why it has less motor blockage and greater sensory motor differentiation. So for that patient that had spinal anesthesia, that has prolonged motor blockade after return of sensory function, if you are asked which agent would you have preferred with greater sensory motor differentiation, ropivacaine will come into your mind as the answer. All right, it's almost as the protein bound like bupivacaine, okay, and it's about 86% of the drug is eliminated via the kidney. Okay, it's know that it's contraindicated in BS block. Okay, so how do you choose the right local anesthetic? All right, depends on the procedure type, the duration of anesthesia needed, the patient factors, and potential risk. These are some of the things you will consider. Okay, note that adrenaline should not be used to prolong anesthetic effect of local anesthetic agent in areas that are supplied by end arteries like the fingers and toes. Okay, and patients with allergies, you want to select the amides above the ester group. All right, additional effect. Local anesthetic agents have been found to have anti-inflammatory effect, and this they do by reducing the activity of leukocytes. All right, at high concentrations, local anesthetic agents have been found to exhibit antibacterial properties, although in lab studies, but systemic levels during clinical use are too low to confirm this effect. At high doses, local anesthetic agents have been found to have antibacterial properties. Number two, other effect is that local anesthetic agents have been found to have anti-metastatic properties. All right. Although the current evidence from retrospective and post hoc analysis remains inconclusive, and the Cochrane review found inadequate proof for this impact on cancer recurrence. Then for neuropathic pain, IV lidocaine alleviates spontaneous pain, allodynia, and hyperalgesia through mechanism beyond sodium channel blockade. So it's being increasingly used for acute post-surgical pain and to reduce post-operative ileus after colorectal surgery. Okay. All right, this BS block, I'm sure you can read this later on. And there are so many other things here. Okay, that infiltration anesthesia, okay, topical anesthesia, and you talk about the eutectic mixture of local anesthetic agents, the autophoresis, liposomal preparations, and all that. I think we should stop here this evening. Our time is gone. All right. Any comments?